Sleep apnea. The term sleep-related apnea has been defined as periods of complete absence of breathing during sleep. Based on the analysis of breathing patterns, 3 types of sleep apnea have been described. 1. Obstructive apnea, cessation of airflow through the nose or mouth with persistence of diaphragmatic and intercostal muscle activity. 2. Central apnea, cessation of airflow without any diaphragmatic or intercostal muscle activity. 3. Mixed apneas, an initial episode of central apnea followed by a period of obstructive apnea. Hypopnoea is defined as a decrease in airflow at the mouth and nose along with a decreased respiratory effort. Some investigators define hypopnoea as a 1/3 reduction in tidal volume associated with a 4% reduction of oxygen saturation. Obstructive sleep apnea syndrome. This is the most common sleep disorder seen in sleep clinics. The prevalence of obstructive sleep apnea syndrome, OSAS, among middle-aged men and women is estimated to be 1.4% and 1.2 to 2.5%, respectively. The prevalence increases with age, partly due to a gain in weight. OSAS is associated with obesity. Hypertension. The prevalence of OSAS is greater than 25% in hypertensive patients, and in untreated cases of severe OSAS the prevalence of hypertension may be as high as 50%. Gastroesophageal reflux disease, GERD. Smoking. OSAS results from the narrowing and closure of the upper airway during sleep. The pharynx, which lacks supporting cartilage and bone, is the site of the occlusion, which can occur at the level of the velopharynx, oropharynx, or hypopharynx. Owing to the relative hypotonia that occurs during sleep, there is airway closure and the patient then attempts to breathe without success, resulting in oxygen desaturation. This results in arousal, lightening of sleep, and reopening of the airway. Such episodes occur many times each hour during sleep. Arousals can be detected on the electroencephalogram, EEG, and frequent such arousals at the cortical level results in fragmented sleep and excessive daytime somnolence. Conditions causing a narrow upper airway that predispose to OSAS include the following: mucosal edema and inflammation, for example in rhinitis. Anatomical deformities such as micrognathia and retrognathia. Enlarged tongue, soft palate, or uvula, present in Down syndrome and hypothyroidism. Infiltration of pharyngeal tissue, obesity and Prader-Willi syndrome. Structural lesions, enlarged tonsils and adenoids. Cranial base abnormalities, achondroplasia and rheumatoid arthritis. Weakness of pharyngeal and laryngeal dilator muscles, congenital myopathies, muscular dystrophies, medullary lesions and vocal cord paralysis. Increased airway compliance, Marfan syndrome, tracheomalacia, and laryngomalacia. Symptoms. It is essential to take a history from the bed partner as most symptoms occur during sleep. Snoring. Apnoic episodes during sleep. Snorting, gasping, and choking sounds during sleep. Restless sleep due to arousals. Nocturnal sweating. Nocturia. Excessive daytime somnolence. Morning headaches. Mood disturbances. Reduced libido. Personality change. Forgetfulness. Symptoms of GERD. Signs. Obesity, BMI, body weight in kg divided by height in m2, of 25 or more. Collar size, men with a collar size of more than 17 inches, 43 centimeters, and women with one of more than 16 inches, 41 centimeters, are at risk of OSAS. Features of hypothyroidism. Anatomical facial deformities. Enlarged tonsils. Large edematous uvula. Hypertension. Congestive cardiac failure. Diagnosis. In order to obtain as accurate a diagnosis as possible, make sure you do the following. Take an appropriate history from the patient and bed partner. Assess subjective sleepiness using the Epworth Sleepiness Scale. Confirmatory tests. Overnight pulse oximetry. This may be normal and so in a patient with a good history and evidence of daytime sleepiness without any other reason, either polysomnography should be requested or a trial of nasal continuous positive airways pressure, NCPAP, initiated. Polysomnography. This is the investigation of choice. It records the EEG, electrocardiogram, submental electromyogram, airflow at the nose and mouth, and thoracic and abdominal wall movement, respiratory effort. At the same time, SAO2, ECG, leg movements and snoring sounds can be recorded. Additional sensors can be used to assess the patient's body position. More apneas occur in the supine position, and esophageal pH, respiratory effort against an obstructed airway is associated with gastroesophageal reflux. Simultaneous video recording can help in diagnosing apnoic spells with restless sleep due to arousals. Polysomnography helps to determine the presence and type of apnea, and its relation to sleep stage and body position. More apneas occur in the supine position and during rapid eye movement, REM, sleep. The severity of an obstructive sleep apnea, OSA, is determined by the frequency and duration of apneas and hypopnoias, mild 5-15/hour, moderate 15-30/hour and severe 30/hour. NB. The Epworth Sleepiness Scale. How likely are you to doze off or fall asleep in the following situations, in contrast to just feeling tired? Using the following scale, choose the most appropriate response for each situation. Scale. 0 equals would never doze. 1 equals slight chance of dozing. 2 equals moderate chance of dozing. 3 equals high chance of dozing. Situation. 1. Sitting and reading. 2. Watching TV. 3. Sitting inactive in a public place. 4. As a passenger in a car for an hour without a break. 5. Lying down to rest in the afternoon. 6. Sitting and talking to someone. 7. Sitting quietly after a lunch without alcohol. 8. In car while stopped for few minutes in traffic. If your score adds up to 10 or more, you may have significant sleep deprivation or a sleep disorder. Treatment. There are 3 reasons to treat OSA. To relieve symptoms. To reduce the risk of comorbidities associated with OSA. To provide relief from the effects of OSA on others. Weight reduction. When appropriate, weight loss should be encouraged. Obese individuals may develop 2 distinct but often related disorders of nocturnal ventilation, OSA, and obesity hypoventilation syndrome, OHS. Patients with the OHS have daytime hypercapnia and hypoxemia and may eventually develop pulmonary hypertension, right heart failure and polycythemia. Nasal continuous positive airway pressure. Nasal continuous positive airway pressure, NCPAP, introduced in 1981, is now the treatment of choice. The mask covers the nose and the continuous positive airway pressure delivers pressurized air to keep the upper airway open. The pressure is titrated to achieve the optimum pressure needed to reduce the apneas. Once a patient is on NCPAP, regular follow-up with the sleep laboratory is needed to monitor compliance, assess the effect on symptoms, and for regular machine servicing and mask/tubing replacement. Dental appliances. In patients who are not able or are unwilling to use NCPAP, dental devices that advance the tongue or the mandible and hence open the airway are used. Tracheostomy. Prior to NCPAP, this was the treatment of choice. The tube stays capped during the daytime and the person breathes and speaks normally. During the nighttime, when the person is about to retire to bed, the plug is removed, allowing the lungs to breathe directly through the tube. This bypasses any previous obstruction in the upper airway, thereby rectifying the problem. Systemic effects of OSA. Cognitive and psychosocial function complaints of poor memory or impaired attention are common in OSA. These improve with treatment. Nocturnal hyposomnia. Nocturnal hyposomnia is common in OSA and is usually more severe in REM sleep. It leads to increased sympathetic activity, vasoconstriction, raised BP, and cardiac arrhythmias. Cardiac function. Bradycardia, common during apneas, is a result of increased vagal tone caused by fluctuations in intrathoracic pressure and stimulation of the carotid body receptors by hyposomnia. Cerebral perfusion. Intracranial pressure may exceed 50 mmHg during obstructive apneas. This is associated with a reduction in cerebral perfusion pressure. Subsequent arousals lower intracranial pressure and hence increase perfusion. This fluctuation in cerebral blood flow can contribute to chronic vascular stress and stroke. Renal function. OSA is associated with increased release of atrial natriuretic peptide during sleep because of atrial distension. This results in increase in urine output, causing nocturia and enuresis. Endocrine function. Reduced nocturnal growth hormone secretion occurs in children with OSA and contributes to growth retardation. Dysmenorrhea and amenorrhea can occur in women with OSA and may improve with treatment. In some patients with OSA, hyperinsulinemia can occur. Treatment of OSA improves insulin responsiveness in some patients with OSA. Complications of OSA. Accidents. In the UK, patients must inform the Driver and Vehicle Licensing Agency, DVLA, once OSA has been diagnosed. For Group I license holders, private cars, driving must cease until satisfactory control of symptoms has been achieved. For Group II license holders, heavy goods vehicles, driving must cease until satisfactory control of symptoms has been achieved with ongoing compliance with treatment that has been confirmed by a specialist. Increased risk of stroke. Increased risk of myocardial infarction. Increased risk of hypertension. Anesthetic complications. Due to narrow airway, there may be difficulty in intubation.